All right, so I'll get started now. First, I'd like to acknowledge the traditional owners of the land on which we are meeting, and I pay my respects to the elders past and present, and the Aboriginal elders of other communities who may be here today. Good afternoon, everyone. Thank you for joining this month's webinar titled Indoor Air and Accessibility. I'm Sabrina Idrose, a Centre for Safe Air Postdoctoral Research Fellow, and I'll be sharing today's webinar. Today, we will explore the varied indoor air environments where we spend most of our lives and how poor indoor air can exclude vulnerable populations, such as people with chronic illness, respiratory conditions, or immunocompromised individuals from participating fully in public life. Drawing on recent national reports, including the State of Indoor Air in Australia 2025, Associate Professor Wendy Miller and Plum Stone will highlight how indoor air quality is not just a health issue. It's a matter of equity, workplace safety, and human rights. Each speaker will present for up to 20 minutes, followed by a Q&A after all presentations have ended, so please drop your questions in the Q&A section. Our first speaker is Wendy Miller, who is an associate professor at Queensland University of Technology. Her academic career has focused on the technical, social, and regulatory aspects of buildings, energy efficiency, renewable energy, thermal comfort, and resilience. Her most recent work has been on collating and quantifying the state of indoor air in Australian buildings of all types. Over to you, Wendy.
Thanks, Sabrina. Okay. Just checking that you can see the screen.
Yep, it looks great. Thanks, Wendy.
Great, thank you. Just have to work out how to change slides now. Okay, I'd also like to acknowledge the traditional owners of all the lands in which we live and work. I'm currently in southeast Queensland, where it's a lovely sunny day today. So today I just want to give a brief overview of what we know about indoor air quality in Australian buildings. And we need to recognise that buildings have the ability to affect our health, but so does other infrastructure such as water infrastructure, transport, etc. But we're looking specifically in this session at buildings and their ability to affect health. So back in November last year, our organisation, Thrive, which is a Australian Research Council network of researchers and industry, we're looking at indoor air quality, but the big questions relate to not just the air quality, but how does indoor air quality relate to health, to greenhouse gas emissions, to thermal comfort and energy, to climate change, to mechanical systems, what we call dynamic optimization, and collaboration and transformation. So we had a workshop looking at some of those big questions, and from that we looked at producing a report which we released in October this year. So the purpose of this report was as a baseline for quantifying what we know about air quality in Australian buildings, in order to lead to the development and implementation of a national strategy for indoor air quality, because we don't have one at the moment. So the two objectives were to collate what's currently been measured of some indoor air pollutants in Australian buildings, and then to evaluate what do we know and what we don't know and what that might mean for moving forward. So I just wanted to present a brief overview of what was found, but within the context of what is the current regulatory framework. So it's not quite true that we don't have any indoor air quality regulations. There are two sets of regulations that impact on indoor air. One is the National Construction Code. So this is what each of the state building codes draw on. And there is a requirement in those codes for when buildings are designed and constructed that occupied spaces must be ventilated to maintain adequate air quality. So just keep that in mind. The second is Safe Work Australia. So this is for all persons who conduct a business or an undertaking. So this is all businesses, including government businesses, are required to provide and maintain a work environment that is without risk to to health and safety. And air quality is one of the risks that's been identified. So just keep those two things in mind as we move forward, and perhaps as we have a discussion at the end. Within that Safe Work Australia framework, there's a process that's required to be undertaken by all businesses or all persons who operate an enterprise, in that they have to manage the risk of airborne contaminants. They have to monitor, so in the orange, monitor the concentration of the pollutants and perhaps monitor the health of the occupants if there is a high risk. They have to implement controls to manage the risk, and they have to keep good records. Then the first box for the manage risk of airborne contaminants, the aim is either to eliminate the contaminants or to minimise the contaminants if you can't eliminate them. And that process is also stipulated in Safe Work Australia, a fairly standard risk assessment process. What is the likelihood of the risk? What harm can it do? What's known about the risk? Are there ways to minimise or eliminate the risk? And then what's the cost, and how is it proportionate or not to the risk? Those things are also worth keeping in mind when you're looking at both an individual, what can I do about managing the indoor air quality of places that I go to or want to go to, and our process of perhaps engaging with building owners to make places safer for us. So to the report itself, we divided all of the research that we found into different building types. So under the Australian Construction Code, there are 9 classes of buildings, depending on what their main focus is. So there's residential buildings, and they're either, in essence, detached houses or apartments, flats. There are other types of dwellings. There's offices, retail and wholesale buildings, storage facilities, factories, hospitals, etc., etc. So this slide just shows how many buildings there are of each of these different types, and what the estimated total floor area of those buildings in Australia are. This is important because if we want to implement some strategy to manage indoor air, we need to know how many buildings are we talking about. And if part of that strategy is to put indoor air monitors, for example, in buildings, it's not just one per building. We have to think of multiple sensors or monitors in each building. So that's just to give a sense of the scale of the issue. When we did this report, indoor air quality is not just one mix of things. It depends on what contaminants you're actually interested in. So this report that we released last month only concentrates on 10 contaminants as listed in this table. So we decided on these 10 contaminants because it includes the contaminants that the World Health Organization considers to be the highest priority, and also some of the contaminants that are already listed in the National Construction Code. So what's not included in what I'm about to talk about are any evidence about respiratory infections, so no studies that have been done about COVID-19 or RSV or influenza, and no studies about mould. So it's not that those things are not important, it's that we had to focus on something to start with, and certainly the next iterations of this report are expected to include those additional issues. So as an overview, if you look at so we found 106 peer-reviewed scientific publications that reported on measured indoor air quality issues on one or more of the contaminants listed before. That incorporated about 2,000 buildings. We also added to that data set all of the data that's been recorded by NABERS indoor environment quality ratings. So overall, the total number of buildings that have had published data on measured indoor air quality in Australian buildings is less than 0.03% of our total building stock. If you look at the map on the right, it shows where those studies were undertaken by state, and within each state, how many of the studies were done in capital cities as opposed to in the regions. It also shows, so what the distribution of the studies shows is that it's very uneven number of studies between different states, between capital cities and regional areas, between different climate zones. And we found that over 75% of the studies were actually conducted by just 2 research organisations in Australia. So there's a lot that we don't know, and there's a lot of parts of Australia that we don't know anything about. The findings are also just snapshots in time. Whilst the report highlights some of the benefits of the studies, the limitations are really important to understand. In particular, that most of the papers were only measuring indoor air quality for a very short period of time, and that might have just been a few hours, and in a few studies it was up to 1 year. But for most studies it was weeks, or maybe a season or 2 seasons. In most studies, only a small number of rooms or zones within a particular building were looked at. So if it was, for example, a residential study, they might have only done the kitchen, or the kitchen and a bedroom. If it was a school, they might only have done 2 classrooms. If it was an aged care centre, they may have only done the common room, for example. The studies also generally focused on the mean pollutant concentration level, so the mean value of nitrous oxide or CO2, whatever, and there was very minimal discussion on peak concentrations, and generally not much analysis about the duration of the concentrations, because the health impact of indoor air quality depends on both what the pollutant is, what level of concentration it is, but also how long are you exposed to that particular concentration. And then there was also a lot of important information was omitted from a lot of the reports, such as, how many people were in a particular room, what the volume of the room, etc. was. That's important because the concentration levels and solutions to get better air quality depend greatly on the ventilation rate, which depends on the room volume and how many people are there, for example. So I'm just going to quickly go through what's known in different building types. So in our homes, the 2 main sources of pollutants are combustion appliances as internal sources of carbon monoxide, particulate matter, and nitrous oxide, and infiltration. So this is particularly pollutants from traffic emissions and bushfires, for example. What we don't know as a whole, based on the papers that we've examined, is we don't know whether housing in generally has good, bad, or adequate air quality. We don't know whether it's getting better or worse. We don't know how widespread poor indoor air quality might be, whether it's worse in regional areas and cities, worse in apartments than detached houses, etc. So some good and bad things there. But if we just think that the main internal source of poor indoor air quality is combustion appliances, one thing you could consider, and traffic emissions, what would be the health implications from those sources if those sources were eliminated through existing policy directions? For example, in Australia's Paris Agreement, we have carbon reduction targets. We have, at least through one of the political parties' net zero energy goals. The National Construction Code is considering whether to determine whether all future housing should be fully electrified. There are moves to electrify transport. There are moves for energy affordability. All of those existing policy directions have a potential impact on phasing out, for example, gas combustion devices, and phasing out internal combustion motors, at least for passenger transport, for example. Some other policies that have been implemented in other countries that might impact on the air quality in houses and other buildings. For example, in the UK, in homes, all rooms that have a combustion appliance must have a carbon monoxide monitor. In lots of parts of Europe, I think the whole of the EU, you are not allowed to idle your engine if you're in an urban area. So you can't sort of sit outside a school waiting for your kid and have the engine running so you can keep the aircon going, for example. So what do we know about offices? Offices are different to houses. They are impacted both by the external air and by internal sources, so equipment and furnishings, but they're also impacted by the design and operation of the ventilation and heating and cooling system. So offices in general tend to be mechanically ventilated and heating and cooled, which is different to our homes. The indoor air quality measurements are impacted by where the monitoring is placed, and that it will inform future research if we decide to try to push towards mandatory monitoring. We don't know, however, how the indoor air quality in offices is different for different professional services. An example of that is you might have a building where some floors of the building are a general office, others might be engineering practices, or it might even be a GP's practice, for example. So how does the air quality in a GP, in a general practitioner's medical suites differ from the air quality in a general office? In our shops and warehouses, there were very few studies, but we do, from those few studies though, we know that the location of the building relative to main roads and other pollutant sources, but predominantly transport, is a major consideration. We know that different occupants, so workers or customers or visitors, and how many people are in a space at a particular time gives them different exposure times. They're very much impacted by the design of the building and the ventilation system for that building, but also by the age of business equipment. For example, old style printers compared to new printers. Old style, it might be, for example, in a warehouse, forklifts that are diesel powered compared to electric or battery powered. Also by how startup and shutdown procedures for different facilities or shift times, etc. But we don't know anything at all about the indoor air quality in retail, in general retail stores such as grocery stores, clothes stores, etc. We don't know anything about, in Australia, about the indoor air quality in businesses that have a potential for high pollutants. So hairdressing and nail salons in particular, laundromats, places that have sell fragrances, new furniture, etc. There are international studies about these places, but nothing in Australia. We don't know about shopping centres in common areas, and we don't know if any of the businesses operating shops, warehouses, retail, wholesale are meeting their safe work obligations. In our factories, generally, the pollutants seem, but very few studies, but we know that the pollutants are predominantly internal, but different zones within a facility can have different pollutants and concentration levels. For example, if you work in a commercial bakery, if you work in the area where flour is tipped into a mixing vat, you are going to be exposed to much more air pollution than if you're in the baking room, for example. But both short-term and peak concentrations are important, and small businesses and large businesses have different challenges because of the nature of what type of technologies they employ. But we don't know anything about most factories because that's not data that's made public, and so we don't know if safe work obligations are being met or if Safe Work Australia is actually monitoring or requiring factories to report their emissions. Hospitals in general have a diverse range of environments and risks, etc. And a lot of those are managed quite well in hospitals, but there's arguably room for development and further refinement. And there are a number of studies that suggest ways on that. But also we could possibly learn from some of the some of the operation things that hospitals do to inform other buildings. Public buildings include schools, but and there are a number of studies about education buildings, but not many studies about other types of buildings such as sport venues, entertainment venues, public transport buildings, etc., etc. And the same with residential care, which is actually quite a unique class. That's both a home and a community venue and a daily workplace and itinerant workplace, etc. We don't know much about how indoor air quality varies across that sector and between rooms. And in particular for aged care centres, how a heating and ventilation and air conditioning system can perhaps manage to address both the thermal comfort, so the temperature, and the indoor air quality needs, because both dramatically affect elderly people. I'm just going to skip over the disaster management one for time. So just a few thoughts to keep in your head is, so the National Construction Code requires adequate air quality. I would argue that adequate is not an appropriate word. Do we want safe and healthy air? But also for whom? Is it for individuals or for the mean broad public? And where do we want this safe air? Is it all buildings or public buildings? Where do we put our focus on in the first instance? And can the risk management process that we looked at before be used both for us managing our personal health, but also for advocating for public health and for business planning and for policy development? Can we do something around those lines? And that's where I'd like to leave it for today. Thank you very much.
Thank you so much, Wendy, for providing an excellent overview of the State of Indoor Air report. There's no question in the chat yet, but so please drop your questions in the Q&A section and we'll get to them after Plum's presentation. So our next speaker is Plum Stone, who is CEO and founder of the Safer Air Project. Plum has worked in health policy and public affairs for the last 20 years with experience in the UK Parliament, international public affairs agencies, and in-house for patient advocacy organizations. As a result of Plum's professional background and personal lived experience with an immunocompromised and high-risk family, she founded the Safer Air Project with a mission to get indoor air quality recognized as a critical accessibility and inclusion issue for people living with chronic health conditions in order to make indoor air safer for everyone to breathe. Over to you, Plum.
Thank you very much, Sabrina. I'm just going to share my slides. Can you see those?
Yep, it looks great. Thanks.
Okay, amazing. Thanks, everyone. Good afternoon, everyone. I'm Plum Stone. I'm founder of the Safer Air Project. And many thanks to Sabrina and Bill and the Centre for Safe Air for inviting me to join you today. Thanks also to Wendy for sharing such a comprehensive overview of the State of Indoor Air report. It was fantastic to be able to join you in Melbourne when that was launched a few weeks ago, and a brilliant kind of introduction to what I'm going to talk about. You'll certainly see some similarities in the policy options that Wendy discussed in my presentation. Before I begin, I too would like to pay my respects to the Darramurrugal peoples as the traditional owners of the land on which I'm joining you from today, and pay my respects to elders past, present, and emerging. I'm going to give a super quick overview of the Safer Air Project and why we exist, and then really just what we're working towards, which I think you'll see is very, very similar to what Wendy and the team at Thrive are working towards as well. The short answer is it's because something as simple as breathing in shared indoor spaces has become a barrier to accessibility and inclusion, and we'd like to change that. As Sabrina mentioned, I'm a policy and public affairs professional, and what really happened for me was at the start of the pandemic, my personal life collided with my professional life. I've been working in healthcare, public policy and public affairs, and in patient advocacy, and suddenly my own lived experience was at the center of that policy advocacy. at the start of the pandemic, this is really because at the start of the pandemic, I was living in the UK with my young family. And before we went into lockdown, we all became sick. I lost my sense of taste and smell for 2 weeks. And my daughter was hospitalized with a seizure. Thankfully, she recovered, but I unfortunately developed long COVID, which sadly persists. And while both my daughter and I were previously healthy, we obviously both suffered poor health outcomes from that initial infection. And adding to our family's risk, my husband has an autoimmune condition that means he's severely immunocompromised and remains at significantly increased risk from any infection. So with this acute family experience and my policy background, I was immediately kind of just looking for, what are the policy solutions? This can't just be the new normal. What are the policy solutions that mean that we can breathe safely without risk of harm? Additionally, my background working in cancer policy meant I knew all too well that we weren't the only people that were at risk. People living with cancer, face significantly increased risk of poor health outcomes from infection, along with many other people living with chronic health conditions. And I couldn't help wondering about the risks for so many people. And here's just a slide. I think it might be the only one in my presentation that's got any stats. Here's just a slide of some of the most prevalent chronic health conditions that we see in Australia. The data is taken from the ABS. And you can see, actually, once you start pulling apart all of these individual chronic health conditions, actually, it's a huge number of people who face increased risk of poor health outcomes from airborne pathogens. And then, of course, it isn't just airborne pathogens that create a risk. So here's just a video. Wendy will recognize the location. It was filmed at Thrive last year. And it's really just such a great visual for understanding how the air that we breathe, the air that we exhale, moves into a space and how it can fill a space. And yeah, once I really started to understand that and the shared risk, it just became this thing that I couldn't put away into a box. How are we as a family, how are millions of people with chronic health conditions meant to access shared indoor spaces safely if that risk of pathogen transmission was so profound? And of course, it isn't just pathogens that create a risk. As I sort of delved into it, I sort of really discovered, Wendy spoke about chemicals, fragrances, PM 2.5, all of these other airborne pollutants. They all create different risks for different profiles, for different people, for people with different health profiles. So actually, indoor air quality isn't just an accessibility risk from a pathogen perspective, it's an accessibility risk from a PM 2.5 perspective. It's an accessibility risk from a TVOC perspective. But once you start improving indoor air quality for any one of, you can tackle all of these pollutants together. So that's why we founded the Safer Air Project. And you can see Amy, my co-founder, and I pictured here. This was a year ago this week, where we launched our report, Safer Shared Air, a Critical Accessibility and Inclusion Issue, with the former Assistant Minister of Health, Jed Carney, and Dr. Michelle Anandaraja MP, as was. And we've just hosted our second annual event in Parliament House this year with the now Senator Anandaraja, who opened the event as the co-chair of the new Parliamentary Friends of Clean Air Quality. And we were also joined by the new Assistant Minister of Health, Rebecca White MP. So I'm just going to very quickly just look at what the recommendations from that report were, which we're still advocating for. So the report noted that while we've made progress in recognising ramps, signage, lighting, assistive audiology and others as essential accessibility features for inclusive design, we're still failing to see that the risks of the air we share indoors in the same way, and really that it's time to start connecting the dots. So our first recommendation was that the government formally recognise indoor air quality as an accessibility issue. And we called for expanding our thinking on equity, diversity and inclusion to include accessibility for people with invisible chronic health conditions in relation to the invisible air that we share indoors. Since that launch last year, the government have actually run a consultation or are in the process of running a consultation on the Disability Discrimination Act, and we've been engaging in that process. That consultation recently closed for public submissions, but I'd encourage everyone to keep an eye out for opportunities to engage further. The second recommendation that we called for was for indoor air quality performance standards to be set in all public spaces, which can effectively lower the risk of exposure to airborne pathogens or other pollutants, and for this to include all spaces as covered by the Disability Discrimination Act, which is all public spaces. So yeah, it's actually, interestingly, it's a super contentious issue. How do we do it? How do we set it? What are the parameters, etc.? But actually, I think we need to rapidly move beyond letting perfection to be the enemy of the good. We need to start somewhere and ask ourselves, what would make indoor air quality safer for people with chronic health conditions today, and go from there. Third, we highlighted, and Wendy's already spoken about this, we highlighted gaps in workplace health and safety implementation and enforcement, and noted that employers needed to ensure that appropriate steps are taken to prevent exposure to airborne pathogens and other airborne pollutants. Another consultation that has recently closed and we're awaiting the outcomes of was actually run by Safe Work Australia on the draft model code of practice, managing the risks of biological hazards at work. So that will now go through a formal process, and if agreed by the Safe Work Australia members, the draft model code will be provided to the Commonwealth, State and Territory WHS ministers for approval, and could become model code of practice next year. So keep your fingers crossed on that one. It's really good that they're finally recognising those risks. Fourth, we recommended prioritising implementation. Wendy asked the question about where. We recommended prioritising implementation of indoor air quality performance standards in 4 key settings. Schools, education just being such a huge opportunity, healthcare, disability and aged care, so residential settings, as Wendy discussed, and of course workplaces, noting of course that workplaces actually cover all public spaces. So yeah, lots of opportunity for implementation of those standards. Fifth, we had 6, so bear with me. Fifth, we said infection prevention control must be treated as a whole of community issue, and you'll notice there's a QR code. I'll just bring your attention to that now, so you've got time whilst I'm talking. We effectively said that infection prevention and control must be treated as a whole of community issue, not something that's confined to healthcare settings. And so we're very excited to see the newly established Australian Centre for Disease Control has now been, the interim will now be removed. It's now been established from the 1st of January, but we're really keen for infection prevention control to be included in its remit. The QR code will take you to a campaign that's being run by the Australian College of Infection Prevention Control to make that happen. So it's a super easy tool to use. It'll help you send an email to your MP. So I'd encourage everybody to do that now. And then 6th, we called on the Productivity Commission to conduct a benefit cost analysis for investments required to meet indoor air quality performance standards in all public spaces. You can see just at the bottom of that image, one of the things that we included in our report was in fact a very basic cost benefit analysis that took into account just the cost of preventing one case of COVID and the consequent long COVID that occurs. But obviously you can see that improving indoor air quality would have a much greater impact than just preventing one infection of one disease. it would have an impact on flu, RSV, chickenpox, measles, all of these, plus asthma, etc. So the opportunity in terms of the things that it would have an impact on would be much greater. But even at just that one infection of one disease, we still saw a benefit cost ratio of 1.5 to 3.4. So you can see that there is huge potential for a significant financial return. The Productivity Commission have been running a consultation this year, and you can find out more details. I should have included a QR code. You can find out more details by visiting the productivity pitch. And there are lots of submissions that have been made regarding indoor air quality. So just to kind of try and pull it all together, we were really noting that, responsibility for staying safe in the air we share indoors shouldn't rest on the high-risk person, especially when that person is a child. We wouldn't expect a child to boil water to make it safe to drink. And we really need to stop asking high-risk kids to be responsible for the air they share in their classrooms, because it's solvable. We have the tools: ventilation, filtration, disinfection, real-time air quality monitoring. What we really just need is that commitment to act, to mandate indoor air quality performance standards, and to visibly display that data in real time so that people can see it when they walk into a space. Oh, sorry, I pressed the wrong button. I'll go back. Yeah, it shouldn't be on high-risk people. That's the thing we have to kind of change, is that the burden of responsibility is systems level as opposed to individual level. So I just wanted to share, just stepping away from Australia, just about some of the global, the global movement that is happening at the moment. Indoor air quality is increasing in visibility, thankfully, and largely in part to the work of Dr. Bronwyn King, who you can see pictured in the middle, who convened an event at the UN in September, and I was very fortunate to be able to attend with her and so many great Australians here in this picture. One of the things that was announced on that day, and again, sorry, there's a QR code on here if you want to find out more about the global pledge that was launched at the UN, please do follow that link. While we were at the UN, the International Well-Building Institute also announced the formation of a global commission on healthy indoor air. And it's really fantastic to see that both the Global Commission on Healthy Indoor Air and the UN pledge both included accessibility at in their wording. So it's really fantastic to see that through this work, accessibility is being recognised. So just to come back to Australia, I mentioned earlier that we've just hosted our second event in Parliament House. This is not Parliament House, this is the Shine Dome, which is the home of the Australian Academy of Sciences. And to coincide with our event in Parliament House, we also ran a campaign called Making the Invisible Visible. And really the ask on that is getting organisations to commit to monitoring, getting organisations to visibly display that monitoring as the first sort of step. At our event in Parliament, we were very fortunate that the Australian Academy of Sciences also launched their new report on indoor air quality. And the recommendations in that report are obviously incredibly similar to our own. I'm just going to bring up a photograph that I took of Lydia's slide at the time, to remind me of what the ask was, which was a requirement for monitoring without a reporting standard. So that's effectively what we're trying to do with our campaign. The implementation of a reporting standard, and then a legislated indoor air quality standard for all public buildings. So we're on that path, and we were very excited to see a number of organisations from around the world signing up to we're calling it year zero. So we've got a whole year to sort of to fill the map for year one, and to really kind of drive that understanding that monitoring in real time is the only way that organisations are ever going to act. If you can't see that you've got a problem, what are you going to manage? So monitoring is really the first step, but visibly displaying it so that people living with chronic health conditions, people living with risk factors from exposure to poor indoor air quality can access spaces safely, knowing what they're breathing. So yeah, we're really looking forward to filling the map this year. So that's it. Thanks very much. I hope this was of interest, and apologies for those who are joining who have been at our event in Canberra for the crossover in the presentation.
Thank you so much, Plum, for showcasing the great work you and your team are doing on advocacy for safer indoor air for everyone. So now we'll open the floor for any questions that the attendees may have. The first question is from Michael Abramson for Wendy. So Wendy, there's currently a push for all levels of government to simplify the National Building Code to cut red tape and speed up construction of buildings. Is there a risk that indoor air quality could worsen if builders cut corners?
Okay, thanks for the question, Michael. I think, first of all, perhaps don't look at builders cutting corners. And by the way, Sabrina, my video is not enabled. If you want to be able to see me, you have to do something about that.
Yep.
Yeah, so the general approach of the building industry, whenever the National Construction Code tries to, make buildings safer from whether it's fire or energy or whatever, is the building industry saying, is it the role of builders to do this? So for renewable energy, for example, the building industry would say it's up to the individual if they want to put solar panels on their roof or have an EV charger or something like that. And I would imagine they would say something the same about indoor air quality, that it's not the role of builders to do this. Therefore, don't put it in our regulations, do it some other way. I think that's a very poor response, and that's currently the approach that the building industry is taking, particularly the housing industry is taking to the current code requirements for accessibility to make all homes, all residential dwellings meet a certain accessibility standard. The difficulty with that approach is that often the cheapest way to tackle either energy or accessibility or indoor air quality is right at the beginning when buildings are designed and constructed. So I don't support what the building industry says about trying to cut red tape. However, I do understand that the current codes, there are lots of rules, and that can be overwhelming for a lot of in the industry. But rather than reducing the rules and making our buildings somewhat less than what they need to be, we need to find ways of getting the building industry to embrace change and to be able to implement change quickly, rather than avoiding an opportunity that we have to implement change at the construction stage. One example of that is that in the requirements for a benefit cost analysis for introducing building codes, the process does not allow for taking into account that when something new is introduced, industry learns over time, and therefore the cost of implementing something gets cheaper over time. So if, for example, all houses are required to put in a ramp for wheelchair accessibility, in the first year that might cost an average home an extra $1,000. But by year 2 or by year 3, that might be $500. By year 4 or 5, it's essentially nothing, because builders and designers work out how to design the house so that it's not such a big thing anymore. So the rate of change that an industry goes through to reduce costs over time is not something that's currently allowed in the cost-benefit analysis. So we need to address that, for example, if we're looking at air quality. But in my view, we shouldn't be allowing our housing crisis, etc., as a excuse not to implement the very best buildings that we can. We need to find ways to address the time and the upfront cost in order to save the costs that go down the track.
Thanks, Wendy. Plum, this may be a question for you. Bill is working on a proposal for better protecting vulnerable groups, mostly those with chronic health conditions from seasonal respiratory infections. He would be very interested to know more about what safe work can do to ensure less transmission of viruses occurring in the workplace.
Yeah,
I was going to say my answer for that would be that it's not up to Safe Work Australia to make a safe place. It is a legal requirement of each workplace. So if there was a particular workplace that you're looking at, Bill, I would be asking that workplace, what is your strategy for managing respiratory transmission in this workplace? So, for example, in schools, there is an exclusion time that if a child has a respiratory illness, they are meant to be excluded from school for that period of that transmission risk, in essence. So I would be looking at the risk assessment process that I sort of showed before and asking that of my employer or the building that I want to go to or something and say, show me what the strategy for this workplace is to reduce the risk of respiratory infection or pathogen transmission.
Yeah, that's the perfect answer. The consultation that I mentioned, Bill, is obviously sort of currently closed for public consultation, but we will see the results of that in the next couple of months. And I can't work out how to put it. Maybe if I just type the answer, I can pop the link to that biological hazards consultation in the chat for you so that you can see it. But yes, absolutely. The role of Safe Work Australia, there's one of the slides that I have in a different presentation talks about how your boss cannot make you sick or cause you harm. Well, what is the ventilation? What is the air quality like in order to prevent you getting sick? We've done a fair bit of work on this, and I'm happy to answer any questions that you've got if you're building something that's broader than just one workplace. I'd be happy to chat offline about it.
Thanks, Wendy and Plum. There's another question from Michael, I guess to you both. He said that there's a move to introduce an indoor air quality standard for NO2, which was blocked by the gas industry in 1990s. There are probably still vested interests that would oppose proposals to regulate indoor air. How can this be overcome?
I think, first of all, that the gas industry is not someone that I would would give over control of the air that I breathe. They don't own the air. They don't own the internal spaces, and I think, therefore, their views should be ignored. But generally speaking, I think Australia could learn from what other countries have done on this. So, as mentioned, in the UK, I think in about 2023, it became a requirement that if you have any gas appliances or combustion appliances in a home, for example, you must have a CO monitor. I think that's a fairly easy thing for Australia to implement. We already have one form of indoor air monitor in every building space in Australia, and that's a fire alarm, a smoke alarm. That's an indoor air monitor. Adding a CO monitor for all spaces that have a combustion device would at least allow people in those spaces to see when it's at a high level or see if there's an issue. I don't think it's anything to do with the gas industry per se.
Thanks, Wendy. Tom, do you have anything to add to that, or we can move on to the next question?
No. I always enjoy the reflection to fire, smoke detectors. We have, Wendy's totally right. We have these indoor air quality monitors in every public space, in every room. So the notion that we can't do broader indoor air quality monitoring just falls over as soon as you kind of use that analogy, because of course we already do it. So yeah, it's I totally agree. It's very doable. I'm not from an NO2 perspective, that's not my area of expertise. Obviously, in terms of the standards that we are initially looking at, we would sort of default to Lydia's paper from last year, and the parameters that were included in that, which were obviously CO2, CO, PM2.5, and ventilation rate. So that, I think, is probably the easiest place to start.
Thanks, Plum. There's a question from Daniel. He mentioned that there are a few policies around public places such as schools and childcare centers, but the most ignored one is private property, where people at risk spend 90% of their time. For example, children are significantly exposed to indoor air pollutants and secondhand smoke. Could both or one of you comment on any progress regarding indoor air policies around private properties?
That's a tricky one. From a politician's point of view, there's a lot of reluctance to tell people what to do in their homes, in a sense. But having said that, we do stipulate that you must have the smoke alarms, for example. So there are examples. The secondhand smoke is a difficult one, and I think not something that regulators can do within homes. But in terms of pollutants from gas appliances or from wood heaters, I think the CO monitors, perhaps even PM2.5 monitors, having to gas appliances, for example, putting the reliance on the suppliers of such appliances in homes to show that they're not going to present a health risk, and generally increasing the general public and the politicians' awareness of what are the health impacts of the pollutants that come from combustion appliances, whether those appliances are in homes or in schools, etc. So from the studies that we looked at, I think Victoria is the only place at the moment where any gas appliances in schools must be flued, whereas I think in most other jurisdictions it's not required that a gas appliance be flued. Yeah, so it makes no sense in my mind for having gas appliances in public spaces such as schools and childcare centres, and to find ways of encouraging gas appliances to be taken out of private homes, particularly homes where people have chronic illnesses or respiratory illnesses, etc. Yeah.
Thanks, Wendy. And on that note, like Dorothy mentioned that low-cost sensors provide overwhelming evidence that outdoor pollution increases indoor pollution. And she's asking whether planners should take outdoor air quality into consideration and not allow new buildings in areas that exceed WHO outdoor air quality guidelines.
Certainly in the papers that we viewed, in particular, where are schools and childcare centres allowed to be built? A lot of childcare centres, and to a slightly lesser extent schools, are built on major roads. And a lot of them are actually at traffic lights on major roads where you have combustion engines idling for a long time. So I certainly think there is a role for urban planning to take in where they approve, particularly public spaces that involve children, because the risks to them are much higher than the risks to other adults. So one of those mechanisms could be that when someone applies for planning approval for a childcare centre, that it is up to the applicant to prove to the town planners that they have monitored the air the outdoor air in that place, and that they have strategies in place to ensure that that won't present a risk to the occupants of that space. How you go about implementing that, I don't know, but I think perhaps it will take perhaps some legal cases to drive that point home. And there was a legal case in the UK, I think it's called AWAL's law or something like that, where air pollution was shown to be a causation of the death of a young person, and has led to significant changes to ambient air and urban planning issues, particularly in London. I'm not sure how widespread across the UK.
Thanks, Wendy. Plum, did you have anything to add to that, or we can move on?
No, but I think it's a fantastic thing to get included. Would and especially as we look to a increasing acceleration of climate change and deterioration of outdoor air quality. What are we doing when we're building new buildings to ensure that the ventilation strategies that are included in those new builds can protect both now and into the future? I think that's really important. So not just in areas that we know now have poor outdoor air quality, but also for the future.
And that's particularly important for childcare and school settings. I mean, in an office, you can, on a major road, you can put in a really good ventilation system that has all the filters and scrubbers, etc., and the ventilation rates. But for schools and childcare centres, the children spend a lot of time outdoors as part of their daily routines. So having a good building is not enough.
Yeah.
We need to do much more than that for those specific public buildings.
Yep, and I think we're reaching to the end of the webinar, so this will be the last question. So George is a GP and a member of Doctors for the Environment of Australia. And he mentioned that it's extraordinary that there are no regulations or requirements in primary care, and that is that the overwhelming majority of GPs and practice managers have minimal, if any, knowledge about indoor air quality. Shouldn't we target Australia's healthcare facilities?
Yeah, absolutely. I mean, George, one of the we set out 4 priority settings for action on improving indoor air quality, and healthcare was right up there. We cannot have a situation where high risk people, as in every single person accessing healthcare, is put at risk in accessing the healthcare that we need. We have a Charter of Healthcare Rights. It says that access should be safe. People should be able to access the care that they need, and care should be respectful. And for many people, accessing healthcare while wearing respirators, getting healthcare workers to wear respirators, we're certainly not in a respectful. People are not having those rights met. So yes, absolutely, healthcare is one of the critical settings that we need to improve, along with residential care settings as well.
And I would also add to that under workplace health and safety, GP clinics have the same legal obligations as any other enterprise, that you are meant to ensure that no harm occurs to your workers and to anybody that enters your business. But from a buildings perspective, there is no difference in the building code regarding the ventilation requirements for a general office compared to the ventilation requirements for a GP surgery. So it's really up to the GP surgery and I guess their building designers, or when they're retrofitting an office or something like that, we're in some ways reliant on their knowledge about what are the additional risks that happen in a GP surgery compared to an architect's office or an accountant's office, for example. And there's no evidence that is happening. So, maybe one of the things that needs to happen is that there is some education campaign of GPs and of practice managers regarding what are the indoor air quality risks to them, and what are the ventilation strategies that they could apply to their practices to ensure that they're meeting their current legal obligations.
Thank you so much, Plum and Wendy. So as we conclude today's webinar, I'd like to extend my sincere appreciation to the both of you for sharing your time and insights on this topic. I echo Jocelyn's comment and she just wanted to say that how much she appreciated your appreciations. She said that since 2020, she's become more aware of what shared air actually means and the implications for her own health as well as her loved ones. So thank you for the work that you do. We also hope that the attendees have found the discussion valuable and informative. If you have any further questions or would like additional resources, please don't hesitate to reach out to the Centre for Safe Air. We look forward to seeing you at our next webinar. Thank you, everyone, and have a great day. Bye-bye.
Yeah, thanks, everyone.
Thank you.